Welcome back to the channel. Today we're diving into a practical overview of rheumatoid arthritis, specifically designed for clinicians. Rheumatoid arthritis is a chronic systemic autoimmune disease of unknown cause that primarily affects the joints. It typically presents with symmetrical pain and inflammation of the small joints of the hands and feet. Because it is a systemic disease, it can also involve multiple organs outside the joints. Rheumatoid arthritis can be classified as seropositive or seronegative. The seropositive form is diagnosed when rheumatoid factor or anti-CCP antibodies are present in the blood. The seronegative form refers to patients in whom these antibodies cannot be detected. A specific subtype is late-onset rheumatoid arthritis, abbreviated LORA, which appears in patients older than 60 years. This form is often more aggressive compared with rheumatoid arthritis occurring in younger patients. There are also early forms of the disease. Early rheumatoid arthritis, or ERA, refers to cases diagnosed within 6 months from the onset of symptoms. Very early rheumatoid arthritis, abbreviated VERA, refers to cases diagnosed within the first 3 months after symptoms begin. Diagnosis is based on the ACR-Euler classification criteria. Rheumatoid arthritis is considered likely when the patient reaches 6 or more points on the scoring system and presents with synovitis in at least one typical joint, which cannot be explained by another condition. Clinically, the disease usually presents as a symmetrical inflammatory polyarthritis. Patients often develop swelling and pain in the small joints of the hands and feet. Inflammation may also affect the tendon sheaths and bursae, leading to tenosynovitis, tendovaginitis, or bursitis. Baker cysts may appear in the knee. One of the most characteristic symptoms is morning stiffness lasting longer than 60 minutes. Another classical manifestation is the presence of rheumatoid nodules. These are painless subcutaneous nodules usually located at the olecranon, the dorsal side of the hands, the heels, or the knees. They are typically firm, mobile under the skin, and composed of immune cells such as macrophages. Because rheumatoid arthritis is a systemic disease, extra-articular manifestations can occur. These include nail fold abnormalities, pleuritis, interstitial lung disease, pulmonary fibrosis, myocarditis, and keratoconjunctivitis. Patients may also present with non-specific symptoms such as fatigue, myalgia, or night sweats. An important observation is that the vertebral column and the distal interphalangeal joints of the fingers are usually not affected, which helps differentiate rheumatoid arthritis from other joint diseases. Diagnosis combines clinical findings with laboratory and imaging tests. One clinical sign sometimes described is the Gainsland sign, where applying pressure to the hand during a handshake produces pain. Laboratory tests usually show elevated inflammatory markers such as C-reactive protein and erythrocyte sedimentation rate. Leukocytosis, thrombocytosis, and increased ferritin may also occur. Rheumatoid factor represents antibodies directed against the Fc fragment of IgG. Although IgM rheumatoid factor is most commonly measured, IgA and IgG types also exist. Anti-CCP antibodies are highly specific for rheumatoid arthritis. Anti-nuclear antibodies, or ANA, may also be detected to help differentiate it from other connective tissue diseases. Imaging studies play an important role. Ultrasound of the joints can detect early findings such as joint effusion, tenosynovitis, and early bone destruction. X-rays of the hands and feet are routinely performed, though the absence of changes does not exclude the disease. MRI with contrast and bone scintigraphy may also be used. Finally, joint aspiration can help exclude infectious causes of arthritis. Treatment should begin as early as possible after diagnosis, because early therapy significantly improves long-term outcomes. During the acute phase, glucocorticoids such as prednisolone may be used, typically starting at 10 to 30 milligrams per day before tapering. This is often combined with NSAIDs or COX-2 inhibitors. The first-line long-term therapy is methotrexate, usually between 7.5 and 25 milligrams once weekly, adjusted based on clinical response. Folic acid is administered 24 to 48 hours after methotrexate in order to reduce adverse effects. Methotrexate is contraindicated in pregnancy, breastfeeding, severe liver disease, and significant renal impairment. If methotrexate is insufficient, second-line therapies include leflunomide or sulfasalazine. Sulfasalazine is considered safer during pregnancy. Another option is hydroxychloroquine. Combination therapy is often used, such as methotrexate combined with sulfasalazine and hydroxychloroquine. If conventional therapies fail, the next step involves biologic agents, including TNF-alpha inhibitors, IL-6 inhibitors, or JAK inhibitors. Early diagnosis and treatment remain the key factors for preventing joint destruction and long-term disability. Thanks for watching this clinical overview. If you found this helpful, please like and subscribe for more medical education content. I'll see you in the next one.